Hi, everybody. Whoa, that's really loud. Maybe I'll hold it like this. Sorry. I see some familiar faces from the previous breakout session that was here. But for those of you who don't know me, my name is Henry Budenchain. I'm a senior capacity building coordinator at Health HIV. Thank you for coming to this breakout session. A couple of things that I didn't mention in the last breakout session. There are restrooms just down this hallway. So if you exit this door, they're just down the hallway. If you exit that door, come down this way and then turn right. And then once this session is done, there will be a little breakout room on this floor. So basically how you get there is you can go down this hallway, and it's called the hangout, I believe, or you can go kind of the way you came up. If you, instead of coming into this room, you turn to the right, you'll pretty much see it. So if you all would be able to, once we break out, go there, just chat amongst yourselves, and then we'll have another session following. You don't have to go to that session. You can go to a different session. But if you want to go to that, it'll be following this one. Okay, great. So now I will just introduce Joseph here, who joined Washington Health Institute in October 2019 and serves as the Early Intervention Services and Outreach and Prevention Program Manager and Case Manager. A proud Bostonian and Cabo Verdean, Joey received his Bachelor of Science in Behavioral Health Science with an emphasis in childhood and adolescence behavior management from LaSalle College and dual Masters in Social Work and Public Health from Howard University. Joey has a special interest in dialect behavior therapy, social emotional learning, and sexual orientation, gender identity. He is passionate about helping individuals and families who may have limited access to healthcare and are experiencing discrimination, poverty, and living in dangerous environments. Joey loves to watch his patients actively take power for their health and sexuality. Outside of the office, he can be found hiking, swimming, working in the garden, or brushing up on his cocktail recipes. So, Joey, thank you for being here. I will turn it over to you.
Good afternoon, everyone. How is everyone doing today? All right, let's see a little lackluster again. I'll try again. How are we doing this afternoon? There we go. There's the energy I was looking for. So firstly, what I would love for everyone to do is go ahead and take their hand and put it up in the air just like this. And then you're going to make a chicken wing like this. And then go ahead and give yourself a pat on the back for being present today. A lot of our colleagues, I know for where we are at Washington Health, would love to be here and just get a chance to meet other folks who are like-minded. And we just want to go ahead and create that atmosphere, so I thank you all for coming and being present. With that said, I'm going to go ahead and dive on into the behavioral health models for integrated care and risk reduction. Firstly, with that, what I want to do is just introduce you to Washington Health Institute. Washington Health Institute was founded with the mission to improve the health of our community members by providing exceptional primary and infectious disease specialty care services. We approach the unique needs of each individual by providing holistic care support and the patient education while participating in innovative research that advances the quality of the lives of our patients. Some of the big things we are known for is our primary care, specifically our infectious disease. We do provide COVID-19 testing, telemedication, preventative care, on-site phlebotomy, and behavioral health, as well as our peer support groups. More specifically, within the integrated behavioral health model, we have our Ryan White holistic care program. What we like to do is not necessarily just treat the disease or treat the issue at hand. We look at it as an individual that we're trying to assist. A lot of times I like to tell my patients, I'm here to help you live your best healthy sex life. So whatever's helping you stop you from doing that, I'm here to address it. Whether it's childcare, finding food, getting connected to preventative services, we are here to do that. A lot of them like to call me a little pit bull because once again, you put it on a bone, send it out there, and me and my team are going out there. We provide medical and non-medical case management. We also provide mental health and substance abuse peer recovery specialist who is phenomenal and just started with us a couple months ago. And she's really uplifted the program by, being part of the team meeting people where they're at, and just kind of being their home slice and their home girl. A lot of our times our patients come in because they want that care of just not talking to a provider, but talking to someone who understands and will have that real, genuine connection with them. We build rapport, specifically with our integrated behavioral health therapists as well. And then we also have our patient health navigators who are status neutral. I'm actually lucky to have two of my people here. We have Darmani Fairmore right over here, who is our HIV care specialist. Specifically, he works with folks and, again, addressing those mental health issues as well as substance issues. And then we have Carlton Mays right over here, who is our PrEP navigator, who helps with folks on the opposite side. What we like to do is, again, that status neutral holistic care that regardless of what present issues are in your life, we want to address them and help you live that long longevity life. Lastly, one of our bigger programs is the Ron Simmons Wellness Program, where actually folks are getting a chance to work on their grief and work on specific issues within their own personal lives. A lot of that has to do with just not the meeting with a clinician, but then also looking at other holistic opportunities such as getting massage, getting an acupuncturist, going to a dance studio. Mental health isn't just about sitting down and talking with someone or taking medication, but finding the different coping mechanisms that help you as an individual go ahead and progress with whatever issues that you're dealing with. So what is integrated? What is it exactly? So it's basically the results that, it's the care results that come from a practical team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. That's how they describe it. For us, it's just the intersection between physical and mental health, right? You can't have one without the other. If you're lacking in one area, more than often you're lacking in the same area. Meaning, if I'm actively using substances, I have a less chance of actually using my HIV medication. That means I'm not becoming virally suppressed, my viral load's going up, and I'm becoming immunocompromised. It's the same with bipolar, right? If we leave it untreated, how are we to believe that someone who may be suffering from bipolar may also be taking their diabetic medication on time or their insulin if they're going through different episodes, right? If I have depression and it's going untreated, I'm less opportunity to actually go to my doctor's appointments and see my provider because of all the things that I'm going through, right? We know with depression, sometimes it's just kind of that shutting off the world. And if I'm going through that problems, I'm not able to see my provider. So again, it's that mental health with that physical health combined together. What folks may not realize is that within a visit, almost 75% of primary care visits touch on these specific areas, which are behavioral health factors, right? When you're going to your doctor's appointment, your doctor's asking you about your smoking, whether you're actively doing it, your cessation of it. They're asking about your mental health. It may not be a full assessment or it may not be a full conversation, but they are doing assessments and seeing where you are at. If this is happening in the medical visits, why not have that full wraparound and have the opportunity for folks to actually go in and get that care? A lot of times, you start having that conversation, but the doctor says, oh, I'll refer you out, or, just go ahead and Google some stuff. It's not very beneficial because if I could just do that, I would have done it already. This is why, again, that integration between the two, because within primary care providers, they're actually on the front line for providing antidepressants. That means out of all the other folks who are providing it, your primary care provider is more often the one who's providing that medication. So if we're having those conversations, why not do the full linkage or that full commitment for it? With that, it's also a missed opportunity, right? If we're having these conversations and we're seeing this arise in these medical visits, just by having that conversation, it's not doing much, right? We can always acknowledge the problem, but identifying the risk does nothing if we're not helping to reduce the risk, right? Telling someone, oh, if you're sexually active, just use condoms. We know that's not 100% sure. Why not figuring out to them what kind of sex are they having? What type of condoms do they prefer? There are hundreds of different types, whether it's ribbed, whether it's non-latex, or real feel. More than often, if they find the ones that they actually enjoy using, they're more than inclined to use it. So again, creating that behavioral health and helping them merge those two together. So Sampson Purcell identifies 3 different versions of integrated health models. There's the first being the coordinated, the second being the co-located, and the last one being integrated. When it's coordinated, it's basically 2 separate entities working together for the patient. There's zero communication happening. It may happen, but it may not happen. You work in separate facilities. You have separate EMRs, so you track the information you're working with your patients in two different systems. So when those two systems are doing something different, there's no communication happening in real time. Usually clinicians have no experience working in primary care settings, and because of that, they're not going as in-depth with those behavioral health models. When it's co-located, think about it as having it in the same building. Having the ability to kind of say, all right, you're seeing a provider today, let's walk you downstairs to behavioral health. Let me walk you over to a psychiatrist or to a patient health navigator that can help you with these things. Sometimes they share the same scheduling and medical records, so a lot of times you do have a chance to learn what's happening on the other end, but again, it takes that time to do that full investigation. The ultimate and one that we at WHI use and are actively trying to develop and progress is our integrated model. This is practice within the change. It's full collaboration. What that means is you are seeing me and my people in the clinic. The minute the doctor needs us, rather than saying the referral, they're chatting us, hey Carlton, I have a PrEP patient who needs help navigating his medication adherence. Can you come on in actually right now? It's happening in real time where there's a collaboration between the doctors, us, and the patient. It's that care model where we're walking hand in hand together rather than just leading them blindly. The benefits of having an integrated behavioral health model, it provides a one-stop shop. A lot of times our patients will have an appointment at 9 o'clock, but they're not leaving our services in our building until 12, 1 o'clock, because not only did they come see their doctors, but then they also got their labs done in the same exact suite, and then after that went to go see a specialist, specifically whether it was our wellness program, where again, folks get 9 sessions together, half of those being with the clinician who you work on via grief counseling, whether it be grief because of job loss, whether it be grief because you've actually lost someone. We all grieve in different ways and need different processes. So he works with you with those, but then also adds that holistic care of providing those external resources such as a masseuse, right? A lot of times you don't know if a masseuse is going to do you justice and helping calm down those behavior issues because you never experienced it. A lot of times, a lot of our patients have never tried it, and it's about giving them the exposure and giving them the opportunity free of charge at that to try these things out. It benefits the patients, providers, and the caregivers. Again, this is a unification. It's us doing this together, right? By the provider letting me know that this patient is struggling with their behavior issues, specifically around their insulin, or whether it be substance abuse, having those real candid conversations outside the doctor's office and our own office and diving in deep and getting to the nitty-gritty. It improves the quality of care and lowers overall health care expenditures, right? Again, because a lot of it's handled in-house, they're not having to miss multiple hours of work because they have to go to the doctor today and then do the referral tomorrow and then go to the pharmacy the next week. All that's handled in the same exact visit. It allows them to get the full care that they need and go beyond the care that they even thought they could provide or we even thought we could provide. It enhances communication and coordination between the team. Again, by it happening in real time, instead of me doing the referral and talking to you from a distance, I once again am having that conversation with you, and we create interdisciplinary teams where if certain patients need more care, we're actually all pulling together to have those meetings where the provider's involved, the patient health navigator is involved, a case manager is involved, and including behavioral health is also involved. So that way, as a full wraparound, we're figuring out what type of help can we do for this person. Next, I'm just going to go ahead and go through our current model. Again, with this integrated behavioral health, what we thought would be beneficial is to talk about what we're doing and how we're doing it to help folks see that it is obtainable and that it can happen in real life. A lot of times, yep, got a question? Oh, a lot of times, we have these great ideas and these great notions of what we want to do, but if you can't apply it or can't do it in real time, what's the point of having those discussions or meetings? So with us, it starts actually off in our early interventions team. That's me and my team down here. What we do is we're prevention and outreach. So we're getting into the community and providing these services to folks. What we do typically is we get into the community, we provide HIV and Hep C testing for free, regardless of insurance, regardless of any barriers. All you have to do is just commit to the 25 to 30 minutes of the actual test, because the first thing that starts off is knowing your status, knowing where you sit along that spectrum, because you can't take the next step unless you know where you're starting off. Sorry. Oh, sorry, I apologize. But so again, we implement the high five model, which is find them, teach them, test them, link them, keep them. Right? Again, we're heading into the communities and we're finding them where they're at. We're going to the sex parties. We're going to wards 8, 7, and 8. We're going to wards 5, where we're in our own backyard, and we're finding the people where they're at and giving them those opportunities to learn more. We're teaching them about not necessarily the activities they're doing, but about the risk management that can happen. Again, we let them know we're here to help you live your best healthy sex life. Whatever is that barrier, whether it be condoms, preventative methods, whether it be safety, we want to figure out what is it stopping you, so that way we can help educate you to help reduce those reduce the risk. We test them again, testing them for HIV, Hep C, letting them become aware of their status, because that is the first thing in ending the HIV epidemic, is knowing where you sit in order to get that care. We're then linking them, so whether it's in-house and getting them connected to our internal integrated behavioral health clinician, or based off of what they would prefer. Sometimes they need something in their own area, or they need something outside their area because of stigma, right? Stigma is a huge hindrance, whether it be HIV, it be drug usage, right? Stigma is the #1 killer across the board altogether. So by creating those opportunities to find them, teach them, test them, we're destigmatizing it, because now we're having those candid conversations and people feel less taboo of asking that weird question. A lot of times in these little meetings when you're working one-on-one with the patients, they're asking the questions that they would ask their homegirl, their best friend, but they're not getting the correct answer. They're getting the answer that their best friend thinks they want to hear. We're telling them straight up, yes, what you just said is correct, or no, let me address that for you. We want to make sure that they're best equipped, and by doing that, again, it's that behavioral health model of that integration. Yep. Yep, so we actually, so during that time period of just having the test running, we're actually doing a harm risk reduction test in the background. So what we're doing is we're asking you about your sexual partners. We're asking you about their statuses. We're asking you about not only what you're doing it, but how you're doing it. What body parts you're using. And then when it comes to our drug usage, folks, what is it that you're using? How are you utilizing it? Where are you getting your needles from? Do you have access to those areas? And figuring out what it is, and then having that conversation to then use that as a plug. All this will happen in that 20 minutes. Obviously, sometimes it'll go a little bit further, because we try to create what I love to call a brave space. A brave instead of space, safe, because we want you to be brave enough to acknowledge the issues that you're struggling with. To be brave enough to say, you know what, I am messing up. I just don't know what to do. Be brave to not only accept the help, but ask for the help. So again, yeah, this is happening all during the rapid testing. And then we do a lot of risk assessments and barrier assessments. So that includes our harm risk reduction plan. Yep. Yeah. Mm-hmm. Mm-hmm. Yes. Mm-hmm. Mm-hmm. Yes. When it comes to substance, we started off in the co-located. WHI has been in existence since May of 2019. Originally, what had happened was they were originally part of Providence Hospital. Two of our main doctors, Jose Bordone and Dr. Theo Hodge, and another one of our doctors, Dr. Elion Richard. They originally started off in the infectious disease at Providence Hospital, and when Providence closed down, sadly, a lot of those services got canceled, where they actually banded together to help serve the community members. And with another social worker, they created WHI, where at that time we were specifically focused on re-engaging the people in that population, specifically for our folks who were living with HIV. In the last year, we have transitioned through, with the support of HOSTA, to support folks who who have issues in drug dependency. We currently, I believe, in May, April, just hired our first actual peer recovery specialist, specifically for mental health and substance abuse, who is in-house the first 4 hours of the day for the half day, because she's just part-time for now, but we are looking to hire another one for the afternoon. So again, just having the presence in the community, but then also in the clinic, so that way once they do have those conversations, she can just pop up. We are in that, I want to say 75% there to integration, because again, we want to make sure that we have at all times someone available, not just for a certain time of the day. Did that answer your question? Yes. Mhm. Yes. Mhm. Yes. Yep, I want to say for that model specifically, we're about 90% of the way there. Again, our patients come in typically just because I have a doctor appointment, and then one of me and my teams will actually pop into the visit, let them know about our services. There is some stipulations through HOSTA about making under 67,000 and being at risk for HIV or living with HIV. But should those, again, as we know, folks who do struggle with drug usage, they are twice as likely, sometimes 3 times as likely to develop HIV in their lifetime. So that's where me and Carlton would walk in to help them understand PrEP, those preventative methods when it comes to those other stigma issues such as housing, food, and things. Those are all handled sometimes through myself or through my team, because what we do is we have case managers who are also affiliated with other organizations, where if we can't handle it intern and in-house, we actually do not just referral, but we do the warm handoff, where me and the patient will call HIPS together and say, HIPS, where are you all located now? What do you need from the patient? What can the patient do to see you today? And then not just send them, but again, put them in an Uber and say, hey, I'm gonna send you the Uber to see the person there. When you get there, give me a call. Let's also follow up next week to see what transpired. Again, it's just that warm walking in hand rather than just saying, go out the door and go to the left. We're walking down the door to the left, doing that warm handoff. So again, yes, so this is the early interventions. This is the first step. That is me and my team, again, getting into community, getting folks, whether it's out in the clinic or out in the actual communities, getting them aware of their statuses and then doing that linkage. From there, we then have folks come on in and they go to the outpatient ambulatory health services. So when a person does come in, first thing we do is a patient registration, where we go ahead and collect all their information, insurance, and things like that. Should there ever be a barrier preventing them from seeing our doctors, again, that's where our patient health navigators step in to address them and remove them, whether it's applying for Medicaid, Medicare, getting them connected to private insurance if they can afford it, and then helping them reduce those costs still. Regardless if you're making $67,000 here in DC, it is still not a lot. So we want to make sure you're paying as little as possible for these services and medication. We also do Ryan White eligibility screening and or verification. Here in DC, the Ryan White program is a program that is instilled to allow folks who are living with HIV or at risk to get a lot of services that we provide free of charge. So if someone is struggling with drugs and they come in and they're saying, I'm at risk for HIV, let's go ahead and get you enrolled. With that enrollment, you then do a PHQ-9, which is a patient health questionnaire, 4 questions. The first 2 speak directly to anxiety, and the last 2 more to depression. Depending on that score, right in the same visit, because this is, again, they come in, they get the patient registration, they get brought into the room, we explain what Ryan White is and their services to them. The nurse will then come in and the patient does this on their own. Once they actually visit the nurse takes their vital loads, not vital loads, but their vitals, but then also reports this in that same visit. Depending on their score, that's when certain people will be called in. If they get a score of 3 or higher in the first 2, that's when we're going to go ahead and get our wellness or our behavioral health specialist involved. If we have the bottom two, more depression, again, same folks, but then we'll also get our mental health and substance abuse folks involved as well. After that, what then happens is the doctor actually goes into the room where we do the medical evaluation of the visit. We will then introduce the PHQ-9, which is 9 questions now. Specifically, should they score higher than a 3 on that previous score? So again, they walk in, they take that by their own cells. The nurse goes ahead, takes vitals, has that conversation about what that test was, lets them know that this will be something you'll discuss with the doctor. Again, I could have came in just because I have a broken thumb or I have allergies, but we're already assessing my mental health. We're assessing where am I at, because again, the physical, it's all about the integration between the physical and the mental health together. At that time, the PCP will then, the primary care physician does a warm handoff to the behavioral health provider within the house. Our actual health provider is located 3 doors down in the actual suite that we're in from the exam rooms. So again, they get a chat, hey, this person just got a score of this is their background. At that moment, that's when we go ahead and look into our EMR because it's integration, so I get to see what they've discussed with their doctors in the past. When folks do sign on to us, they know that, again, it's not just I'm signing on for a doctor, I'm signing on to be part of your team. At that point, that's when the integrated behavioral health therapist assesses for mental health and substance abuse. We use the SAMIS, which is a well-known substance abuse measurement tool that we'll use to help gauge what type of drugs they're using, the frequency of it, and at what level do we determine them. And at that point, that's when the referral to the Ryan White services get handed off. So that includes medical case managers, non-medical case managers, psychosocial support specialists who can help with anything beyond those that medical and the non-medical will handle. We'll also have the substance abuse services and the Ron Simmons Wellness Program Coordinator involved. Again, it's that full integration of just not the mental health, but then also the support for your behavioral health. From here, that's when we go ahead and use evidence-based assessment tools. So again, we ever use the PHQ-4 and the 9. We're using those as assessment tool, and we're having the conversation with the patient. It's not just you're getting the score and then we're moving on. It's we're discussing, all right, if you're feeling the depression, what areas are you feeling this? Where do you sense this happening? Is it happening certain days? Did it happen over the past 2 weeks? Several months ago? We're getting that full assessment, again, in the same room with the patient. Only time we'll actually remove them from the room is if we feel as though this conversation will go a little bit lengthier over time, and we don't want to disrupt the flow of patients being seen by the providers. From there, we'll do a brief therapy introduction. So for 6 to 8 sessions, for about 15 to 30 minutes, the patients will see us on a regular basis. We typically build these around their already medical visits. So again, rather than having to take off on Tuesday and Thursday because I have to see 2 different people, I'm just taking a couple hours on Thursday to see my medical provider, then seeing you, and then getting my labs done. And every time they typically come, we'll do labs to just go ahead and stay on top of the work that they need. At that point, we'll go ahead and do the behavioral health sessions, which can be performed, again, in the doctor's visits or, again, in our own offices, just depending on the time and the length of assessments that we'll be doing. From there, we go ahead into the supported services. So what we do is we have every month 2 different reports that are filed to us. The first being our retention calls and then our VLS list. Our retention calls is any patient, it highlights any patient who hasn't seen their provider in over 6 months. So the minute you go 6 months and 1 day from seeing your provider, you automatically get ended up on a list that goes to Darmani, who will then not only call you and support you, but then also try to re-engage you. We don't say, oh, let me go ahead and schedule you for a doctor's visit. Hey, I've noticed we've called multiple times. What's going on in life? All right, I can't come because I have these issues here, such as childcare or my job. I just first started my first 90 days and I can't see. So what we do is not just say, okay, I guess I understand. We figure out how do we bridge the 2 connection. Is it potentially one of our doctors has to just stay an extra hour later to see you, or potentially open up an hour later, but figuring out those barriers and addressing them. If it's insurance, getting them linked to the best insurance for them. We actually work with an insurance broker who helps and actually does insurance clinics for us, where again, she's coming into the clinic, meeting with folks who are struggling, and doing the assessments there rather than saying, call me on another day. That integration, again, of that physical and mental health together. We also have our viral suppression list, this being a list that any patient who has a detectable viral load will end up on this list. This is a way for us to maintain and capture folks and make sure they're getting the more assistance that they need. Again, we believe in equity, not necessarily just giving everyone the same, but giving you what you as an individual need. Whether that's creating your own care team model and having them call you once a week to check in, or whether it's us providing Uber helps to all your visits, figuring out what is it stopping you from living that best healthy sex life and addressing those needs. And that's all I have for you today. Any questions? Right back there.
Like 3 questions.
Yep.
But the integrated model seems very comprehensive and but time consuming. So what type of feedback have you gotten from the patients if they have a 9 o'clock appointment, but they're in your office until 12?
Yep. So even though it's comprehensive, we work with the patient. So a lot of times, even though you came in for one service, we'll let you know. So say if today you don't have the time to meet because you have to be at work for 10 o'clock and you didn't build in, we'll go ahead and schedule you for a time to come and meet us. So whether it's next week, during lunchtime, or at 5:30, we create that space for you to be able to do that so we can have you come on in. And a lot of times we do things virtually as well. So whenever you have about 30, 40-minute conversation, chance to have that conversation, let's go ahead and do it over the phone and still get you those resources and get you started and connected.
Okay, so there's some flexibility in that.
Yes.
What statistics are available to speak to the effectiveness of the integrated model?
That, if I'm gonna leave you my email, and then we're gonna have more of a conversation about that. This is something for me. This is a new passion project, so it is something that we've been working on and getting better at. When it comes to the specifics and statistics that are supportive of it, I do not know those off the top of my head, but I will find it and then share it with you.
Okay, I would appreciate that.
Mm-hmm.
And because the reason why I'm asking that is because it seems to me that it's a lot, because what I'm envisioning in my mind is someone come in and they have like you said, a hurt thumb, and then you're calling in your team, and then you're getting the nurse involved, and then the social worker involved. It's like a lot going on at the same time. So I'm just trying to figure out the reality of the program in terms of, funding, money, effective. Like that's a lot. That's a lot to be charged with the responsibility of handling.
Yep. So the way we handle it is team unification. When it comes to an individual coming in, say for that broken thumb, it's about educating them to know that this service is here for them, and we're here willing to work for them. I let tell folks again, I'm your pit bull. So when you're ready to come out to me and see me, I'm going to be available. Whether it's today, hey, I'm a bit hesitant. I just thought I was coming here for this. Cool. What is it you need from me to feel more secure? So that way I can have a meeting with you where I can bring you in and invite you in, and then have you work for our team. Again, these services, the different services, it's not every single individual will be on your team. It's the team that you need specifically. So if you're working with HIV and you're living with HIV, you'd have our Health HIV Navigator, and he'll be the one working with you. When he does his needs assessment, this needs assessment goes beyond just the care. It's talking about your housing stability. It's talking about your income, food, the dependents you have. From there, we have a conversation where a team can be created. So we have that conversation of, all right, based off this needs assessment, it sees you're struggling in these areas here. Here are the ways we can help you, and here are the people who can. When I mean people are ready to jump on in, it's because if the patient's ready right then and there to hop on in, cool, let me invite the person in. Oh, you're not just ready? Cool, what is it, again, that I need to do for you to get you best equipped so that way you're comfortable and ready to see the non-medical case manager for that housing assistance and to help you look for food resources. In terms of the funding, it does get provided to us through HOSTA, as we know that the money isn't always necessarily the strongest vantage point, so that's why we like to try to handle things internally, because we as different providers and different backgrounds come equipped where, again, if we can't handle it, we know the different folks in the city that we could develop MOUs and partnerships with that can assist us in that area. Again, rather than just dumping them on them, it's, hey, Miss Taisha at Housing Counseling, I have this patient who's struggling. What can me and you do together for this patient? Oh, I'm sorry. Oh,
Well, he started.
my apologies.
For patients who test positive on the PHQ-4, I have two questions. One is, um, usually how willing are they to see a behavioral health therapist after that? And for those that are willing, how often do they drop out early from the brief therapy model of 6 to 8 sessions?
Yep. So when it comes to them willing to sign on, our doctors build a great rapport with our individuals, with our patients. Where I want to say about 90% of them actually, that same visit will want that type of service. A lot of times that we find it that people just aren't aware that these services are available to them for free. Again, these are no cost to them. It's all provided through HRSA, through HOSTA, through the Ryan White program, which allows us to do these works for them for free. So a lot of times we just have to remind them that, yeah, you may not want to do it today, but these are free services that's available when you're ready. So just because you're denying me today doesn't mean your next visit I'm not going to pop by and say, hey, Mr. Carter, how are you doing? It's me, Joey. Just a reminder, if you need me, I'm right here. If not, I'll just pop in next time and see you. Yep. Yep. So actually, we on our staff we are very diverse. When the patients come to see us, we have one African American doctor. We have a Latin speaking two Latin speaking doctors, a white woman, two white women. So there is variety across the providers. And then when it goes to our medical assistants, we do have two medical assistants who identify as African American, and then two more who identify as Hispanic and Latin speaking. Then we go across the hall, where support services are. Me and my team all represent three African American black men. Our wellness coordinator is also African American gay black man who's living with HIV. We also have a peer support specialist who's a black woman, and then we also have Blue, who is our substance abuse and mental health provider. Recovery specialist. She is also someone who's living in recovery and is also a black woman. So we, as a staff model, one of the things we want to do is help make sure our staff represents who our patients are seeing. That cultural competency is actually one of the most important things for me. And again, I understand it's not about the race, but it's about that cultural competency of me saying, I'm coming in and I'm telling you that I can't file child care for my 3 kids. And immediately having an understanding of what those issues may be without you having to verbally say it. As an out loud gay black man, one of my biggest things when I work with my gay men is I tell them all the time, there is no particular pattern for what HIV can affect. HIV is blind. It is more prevalent in our community because of stigma. Again, going back to that stigma is the number one killer, so having those candid conversations. A lot of times me and my peers, we're using the same words that our patients are using, right? I'm not coming to you and talking to you about cunnilingus and all these other things. I'm using the words you're using. I'm talking not necessarily the exact way, but making it that brave space so we can have that candid conversation. I want to say 95% of the time patients walk in, we can see them being guarded. I don't want to talk to you. I've already spoken to someone like you at this other clinic and stuff like that. And by the time the conversation ends, it's, so Joey, will you give me a phone call so we can continue this? A lot of our patients, they walk in. Sometimes it's chaotic because, I have my own schedule, but then people walk in. But they walk in because they know they're going to get the help, and we're going to work with them. We're not saying we're higher than or we're better than because we have degrees. I could just as easily be at the end of the table as a gay black man, as someone who's getting HIV. We want to create that space again where folks see themselves in us, so that way we can have those candid conversations and you not feel as though I'm overstepping. And sometimes we do have, in the past we've had Caucasian staff who work with us. One of the things we try to do is make sure they're as competent and understanding as possible. And then also for us as a gay black man, I may not understand the trans lifestyle, but it's something I get the training on and make sure our staff are understanding of to, again, have that diversity and be able to work with a collection of folks, regardless of race, gender, sexuality, or immigration status.
My question, I guess, is just I wanted to ask. I know that they're trying to move towards an approach that create better outcomes for patients. So is this in line with that transformative approach? Where patients used to come and you just give, here, you take this, you go do this, but bringing them into the conversation to let them communicate what is going on with them, what they need, or to communicate on what you gave me, how it worked. Can we try this? Is that more in line with that?
Yes.
Okay.
We believe in motivational interviewing. A lot of times with our patients, we let them out. It's a conversation. It's me and you together, right? I'm here to help you identify the risk, but it's on you to actually reduce the risk. When we reduce it, we're figuring out what works for you, right? Billy may smoke 7 blunts a day, but then it's, Billy, how soon do you think you could go down to 5 blunts a day? On a scale of 1 to 10, I think I'm a 7. All right, why aren't you a 4? What makes you a 7 and not so low? I understand the importance of it, cash, whatever reason. Good. Let's build off of those reasons there. I want to know where you're at, because change can't happen until I understand where you are on that change continuum. Not all of our... Mm-hmm. Yes. Mm-hmm. 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 Yes. Mm-hmm. Yeah. Yeah. I'm frank with my patients. Some of my patients, they'll be like, oh, Joe, I'll get you my paperwork next week. And 2 weeks has passed. I'm still waiting. Oh, this happened. I hear you. But again, we're working on this together, right? I can only do so much for you until you meet me to a certain degree. Again, we let our folks know our doors are open, because sometimes some of our patients they'll see a need get fixed and think, oh, my life is all set. And then 2 weeks later come to us with a different reason. A lot of times our patients see us more than the providers. So a lot of that times we have these end of day huddles where we meet with our providers and talk about, hey, who did you see today? What are issues? Where can we gain some folks? It's that reverse of conversation. It's not just one way, it's a two-way conversation, with it being that we share the same EMR. Our doctors are actively reading, what did Joey do with Mr. Johnson yesterday? Oh, okay, you addressed his housing. Great, because he mentioned to me earlier he was struggling with his meds. I didn't realize because he didn't have housing, he wasn't taking his meds properly. Cool, if that's the issue, it's that continuum. And we like to tell folks that you may be done with me today or this week, but 5 months from now, 12 months from now, I may see you again, or you may see someone else on my team in a different capacity. It's just, again, keeping them, linking them, keeping them in that circle of, we addressed the housing issue, now let's address whatever is changed in your life. Mm-hmm. Mm-hmm. Yes. Mm-hmm. Mm-hmm. Yep. Mm-hmm. Yeah, no, I think that's 100% is that we don't want to always just address and fix, but how do we care on that longer spectrum? And I think that's where for us it's about that re-engagement and then creating those interactions with our patients where we can have those candid conversations of, all right, I see you're struggling in this area. This may not be something I specialize in, but on my team, because we do I can never say this word correctly, we basically, depending on a patient, if they have high needs, we'll actually all come together and figure out what is it we can do internally and what is it we need to use external resources for. We are always constantly redeveloping and training our peer navigators, our patient navigators, even myself. We're actively always trying to train ourselves to be better in different facets. So I think, especially with diabetics, that is something in the future we want to start including with outreach. Our game plan is to start having our medical assistants actually go down with us. We're in the community and we're doing the HIV testing. They're the ones doing the assessments for hypertension, for diabetes, helping folks understand and manage and have those candid conversations, because we find that a lot of times doctors talk in pages, but patients listen in sound bites. So our job is to be the spark notes, to encapsulate and hear both ends and make sure everyone's on the same page. And then if there is that miscommunication, what is it we need to do to address it? And then what do we need to do longevity to make sure no other patient falls in the system? It's that constant reevaluation. It's time spent a lot of times, but I think that's where all of us are hired for our passion for our work. I think everyone that we've hired fits or understands a specific population that they want to represent, and we make sure that they are seen by those folks. We have so doctors talk in pages, patients listen in sound bites, were the spark notes. So it's, I heard my doctor mention I should take my medicine. Did you hear why? Did you hear how often? How much? Honestly, no. Okay, cool. Let's go ahead and go talk to Dr. Hodge, or wait right here, let me run on over. The amount of running we do, I may not look in shape, but my endurance has gotten better from that back and forth. Even my folks, I think our folks are constantly looking for ways to make sure we are actively supporting our patients, because I like to tell my patients, because a lot of times with my family being immigrants from West Africa, they understand that, oh, I'm coming to you for this and that's all I want. Nope. My job, if you don't come to me with your issues, I'm just sitting here and being paid for nothing. I need your problems. I need what you're struggling in to make sure I'm doing my job. Because when it comes to that evaluation of my job, Joey, how many patients are you working with? To what degree have you assisted them? And we understand there are setbacks. There's no forward moving with a lot of these populations, right? If it was clear cut and easy, they wouldn't need us, and we wouldn't be in this we wouldn't be in this space having these conversations.
So I think, well, sorry.
I think you answered a lot of what was said when you were explaining.
Mm-hmm. Yes. Mm-hmm. 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 Yep. Mm-hmm. Yep. Yep. So that actually goes back to on the medical end with the physical. Whenever we get a new patient, whether it's their first time with us or they were with us beforehand, we always get a medical history. Part of us in the social work, what we do is actively make sure that's a smooth transitional process. So they're coming up to me. I used to be seen at Whitman Walker. It's just too far. Now I'm down the street from you all. Cool. Do you remember who your case manager was? Do you remember who your doctor was? Yeah. All right. Can you sign this piece of paper that allows me to contact them, hear what they were doing with you, get the resources or get that information sent on over, and then that becomes part of your new existing EMR. When it comes to the integration or folks getting services elsewhere, we find that folks tend to leave where they were to start staying with us because of, again, how many resources we have available in-house, where, again, if I'm not working, I know when I go in that I just have my normal doctor's visit, that I could walk down the hall and see Carlton because I need assistance working on my prep application to get lower cost. And then I can see Blue because I've actually been struggling with my with alcohol now that I'm out of a relationship. And then I also go and knock on Joey's door and just talk BS and just get things off my chest because, again, we make the space for the patients and they know we want to be there and that we're supporting them as much as possible. A lot of times there is that integration where we do have to walk down the street and be like, hey, we can't do this here. Let's call DBH up and have, Danny Johnson, who actually used to work for us beforehand, now works there. Rather than calling his main line, we're calling his cell phone. Hey, Danny, I have this patient here. What can you do for us? What do they need? And again, doing that warm handoff of rather than just saying, go see Danny. Hey, Danny, what can I do to make sure your job's easier so this transition or this assistance or linkage is as seamless as possible? We also offer Uber health services. So a lot of times where our patients, regardless of where they are, if they need to go to a medical provider such as us or someone we're sending them to, we'll actually put them in the Uber. It picks them up, sends them, and then sends them back. And then some of our folks, we actually go ahead and just give them Metro cards and tokens to make sure that they can visit other medical providers in the future. For us, it's all about instilling, I think, the gentleman back there had mentioned just that walking care, but then also just that ease of mind and giving them that realistic approach and making it as real as possible.
Well, I'm sorry. I have to cut it off because we only... Okay, this is the last question then.
Mm-hmm. 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 Mm-mm. Oh, that's okay, yeah. Yeah. Nope, not private. Folks who come on in. Yep, so folks can walk in, they can go through DBH. We get referrals through a lot of our partner services. I work specifically with a wider circle they have a hub down in Ward 8 where we actively visit them and do testing for them and then link the patients back. We create opportunities I think we're a one-stop shop. A lot of times that's how my selling point is. I tell folks again that when you walk in, you're not just getting the one thing you're looking for. There's so many other resources available for you where you don't have to run around and go to different floors or is this the right suite? You walk in our doors, I need food. 4 people are walking up to you and be like, what is your qualifications? What are your things? All right, cool. You're more of this person. Or, I'm struggling with my mental health. Cool, let's get you routed to that service. It's, again, I think that one-stop shop, creating that space where they feel comfortable and they want to come. Our peer support groups, we run every second and fourth Friday. Typically, it's from 10 a.m. to 12 p.m. I want to say they're usually there until we ended at 12. The patients linger around our waiting rooms and our offices until 2, 3 o'clock, and there's no work being done. It's just they just feel so comfortable being around us where they just want to be there because it's a safe space for them to explore themselves. A lot of times for myself, I tell people, and especially for our psychosocial specialists, treat us like your homegirls, treat us like your home people. When you're stressed, call me because when you're stressed, you're not thinking about the medication you should be taking about. You're not thinking about your insulin and do you have the right medication. You're not thinking about your needles and do I need more needles, right? So whatever's stressing you out, I need to know to best assist. So a lot of times I tell them closed mouths don't get fed, but at the same time, I'm gonna make sure you get fed. I'm gonna throw ample information your way, whether it's too much or too little. Cool, let's now sit down, reassess, and re-engage.
Yeah, okay. Sorry that we have to cut it off. I know that this discussion could go on. We do have a networking session, though, so I'm hopeful that we can continue with this all day.
Yes, and this is our information right up here. Do give a call. If you ask for Joey, they'll patch you right over to my cell phone.
Awesome. Thanks, everyone. Thank
Yep,
you,
no
Joey.
problem. Thank
It was
you.
great.